Ladies and gentlemen, welcome to this evening's webinar, which is focusing on how we might enable the person with a learning disability and their family or carers to participate in pressure ulcer preventive care, and how we might support safe and compassionate delivery of care. Sadly, one of our panel members is unable to be with us this evening due to a sudden bereavement, and on behalf of the panel, we extend our deepest condolences. However, I'm very pleased to introduce Ailish McNeill and Jonathan Guy, who bring a lot of experience as well as different perspectives to the discussion. So we'll start with a round of introductions. My name's Jeannie Donnelly. I'm a lead nurse in tissue viability within the Belfast Health and Social Care Trust, and I'm also an honorary senior lecturer within the School of Nursing and Midwifery in Queen's University. So I'll go to Jonathan. Jonathan, would you like to introduce yourself?
I'm currently employed as a teacher in a mainstream primary school, but previously I was working as a team leader in an ARP, so an additional resource provision for children with a range of different needs. And prior to that, I also worked as a senior care worker in an adults home for adults with learning disabilities and autism.
Thank you, Jonathan. Ailish?
Hi, everyone. You're very welcome this evening. I am delighted to be here as well. My name is Ailish McNeill. I am a registered nurse in learning disabilities, and I've worked in a variety of settings across both inpatient, community, challenging behaviour and autism. I am currently working as a lecturer in the School of Nursing and Midwifery at Queen's University in Belfast, teaching into the learning disability undergrad and postgraduate programs that we have here for student nurses and learning disability.
Thank you both. Ailish, I was just thinking to open, there are people on today's webinar who'll be very experienced in the field of learning disability, and others like myself who are not so. So I wondered, to help all of us that perhaps have a cursory knowledge, could you define what a learning disability is and how it's classified?
Yeah, be delighted to. First of all, I'm going to put a caveat in and say that I will refer to it as a learning disability. And I know in the broader scheme in literature and in other services, it can often be referred to as intellectual disability. So forgive me if you think my terminology is outdated. It is what we use here in the United Kingdom, but I am aware that further afield and with our nearest neighbours here in Ireland that we do use intellectual disabilities. And then I suppose one of the first things I'm going to say, Jeannie, is that people with learning disability, everyone is so different. There are no two people the same. There's no two people the same in the world, thank goodness. But certainly when we come to working with people with a learning disability, there is no two people the same. And if my years of experience have taught me anything, it is that. But there is a classification system for obviously being diagnosed with having a learning disability. And there's, broadly speaking, there's three general criteria for that. So the first is that it needs to be on onset from birth. So often seen in the very early developmental stages, so from those early childhood years. And then we always talk about having a lower intellectual functioning. So things like academic work, kind of problem solving, abstract thinking, and we also talk about a lower adaptive function. So those kind of everyday skills, and perhaps that you and I might take a wee bit more for granted. It's those kind of social interactions, communications, and being able to do things for yourself. And that's not to say that people with learning disabilities cannot learn and cannot overcome some of those adaptive functioning issues, and it just may take a little bit longer. So they may need some more support with it. And that's where often the likes of the roles that Jonathan and I work in to help and facilitate those across all of those areas. Suppose the other thing to say as well, Jeannie, is just that the causes, because quite often learning disability is be caused in a variety of ways. So there can be some of those complications around pregnancy or birth, and quite often maybe oxygen deprivation leading to the likes of cerebral palsy, or we might then see maybe some genetic conditions. And obviously one of the most common that people will think about is Down syndrome. But we also see sometimes it may be related to childhood illnesses. So like meningitis, and we see things like measles as well. So sometimes the cause can be different, which then can lead to varying different degrees of the learning disability. I'm not going to go into the full classification of those, but I suppose it is important to say that some of our folks with learning disability will have other conditions as well. So we call this profound and multiple learning disability. So where someone maybe has Down syndrome and autism and may also have physical health issues as well along with that. And that makes all of those adaptive functionings and everyday life things a little bit more difficult and complicated. And that then determines the level of support that the person needs. So that makes people even more individual.
Yeah, absolutely. So, Eilish, what is the role of the learning disability nurse, and sort of what role do they play in things like pressure ulcer, risk assessment, and skincare?
Yeah, so whenever you're working as a learning disability nurse, it's not the traditional role that you see. It's not what you see on 24 hours in A&E. It's wherever the person with a learning disability happens to be. Jonathan's alluded to some of the services he works in. I've said I worked in a variety of services. So from the start, it's very different. So in terms of the role of the learning disability nurse working with someone and in terms of stopping the pressure and skin damage and prevention of skin damage, it's around that access and equity of access for people with learning disabilities, about making those reasonable adjustments and making sure that all elements are included, that it's not just looked at from a medical model, that we also look at it from a psychological and a social model. So within learning disability nursing, we use the biopsychosocial model quite often. Learning disability nurses are specialists in terms of advocating and communicating and promoting those independence. So because it is more within a biopsychosocial model, it's a busy old job, and it can be wide ranging and all encompassing. It really can. Lots of fun though.
Thank you, Eilish. Jonathan, when we were preparing for this webinar, I had discussed with you about the social model of disability. I'd mentioned it, I'd read this was published by the Disability Rights UK, and I'd found that article really thought-provoking because it described people being disabled by barriers in society, not by their impairment per se. So the barriers that they highlighted were things like physical barriers, people's attitude, the way people communicate, how organizations are run, for example, and how society literally discriminates against those who are perceived as different. And it goes on to talk about the social model language. And that actually rejects that kind of negative or medical language and replaces it with more positive language. And the whole goal is about seeing the whole person rather than the impairment. So I wondered, from your perspective, do you think that language does lead to discrimination? And perhaps maybe provide us with some examples from your practice, if that's okay.
Yeah, language is very important. The way that we talk about things is very, very important, and the choice of words that we use is very important. And I've had this conversation a lot with a lot of different people, and I do think that some people can be
You're just
quite
breaking up a
quick
little bit,
to
Jonathan.
think something. Um, Sorry, I'm worried that's going to keep
You're okay.
happening.
No,
I
no,
don't know if
you're
it's
all
weather or
right.
something terrible.
No, don't
Yeah,
worry.
the way that people choose to talk about something is very, very important. And it's also very important to the person that you are talking about. It can mean a lot to them, how they are spoken about, and what their perception of what you are saying is. I think this comes up a lot with my children in my class, the choice of words that we use to describe people. I had a wonderful interaction with a young boy the other day. We were having a trip to the Science Museum, And we were in the history of the history of medical science, and we came across a straitjacket. And when we were looking at the straitjacket, lots of my students were very curious. What is this tool? What was it used for? And as we began to discuss it, a few of my pupils turned around and they were like, "Oh, so this is for a crazy person. This is for a crazy person. We would use this for a crazy person." I was like, "Okay, let's think about what we've chosen to say." And one of my students was able to stop. And he said, "Oh, not a crazy person, a person with mental health difficulties." And I thought that it was a lovely identification from the child. But the main thing that came to my mind was that he'd used the word person, which was very, very important. And it was also about I just thought about these children. I was thinking about as they grow up, who they will become in the future and what kind of roles they will take. And the association of the word crazy and, what they thought about that. Now, I don't think that there's adults out there in any of our professions that are walking into these people's homes and are using that terminology. But there are things such as what does a care worker or a nurse think when you use the word autism, or when you use the word learning disability or difficulty or need? And that's going to already give you an initial, not prejudice, but there's thoughts and ideas that are going to come to your mind when you have that. And you need to be really mindful of what those are when you walk into that environment, and that you're not letting them dictate the choices that you're going to make or the way that you're going to try and help someone.
Absolutely.
Because like as Ailish with so sorry.
No, you're okay,
as
John.
Ailish was saying, everyone is unique and different. And when you're going into that environment, you need to always be prepared to, first of all, meet the person and understand their needs specifically. And whilst those terminologies and languages can help you to come in with a plan, I think you just always need to be ready to kind of work around that and not let the language guide you, but just use the language as a signifier of possibilities that might come up.
That's really useful. And I think it's very interesting as well, because as soon as you are told something, the word automatically makes you start to think maybe differently about a person before you've actually even given, a chance to find out who that person is and what their abilities are. So I do think that's a really valuable discussion. So moving on from that, education is really important. And obviously the theme of this year's campaign is about delivering pressure ulcer education and care in a much more inclusive way. And Ailish, I'm going to be very honest and say that this campaign has really opened my mind to the fact that people hear and learn differently, and that what we often perceive as challenging behavior can be very much misunderstood. And I often hear in the acute environment that somebody is very challenging, and I'm just wondering, what are your thoughts on that kind of terminology, on that behavior? What is the person trying to tell us?
Ooh, I think this is one that I could possibly go on all evening for. So I would love to hear some of your thoughts in the chat as well, folks. I'm going to stop for a wee minute and ask you then something. So just imagine for a moment that you are in real pain. And the last time that you were in any of these acute environments, acute hospital environments, you had a really poor experience. You're really fearful of needles. You're really fearful of people in white coats. You cannot communicate. You cannot use words to get your message across. Nothing is familiar. You've no familiar people with you. You're waiting for ages. We know how long some of our waiting lists are here. And all of a sudden people are poking and prodding around this thing that's causing you the pain for the reason you're there in the first place. Then you chuck in a whole load of lights and noise and beepers and buzzers and ambulances coming and lots of people around you, and nobody is actually listening to you. Nobody is acknowledging you. Nobody is taking time. How would you feel? Think about that for a wee moment. How would you feel? And I am sure if I was to bring any one of you, and please do put it in the chat if you think I'm wrong, but I would say that every single one of us will react in the same way to that, and we would get annoyed. We might go and complain because we can use our words. For our people with learning disability, and Jonathan's right in saying that it is people first language. It's not about seeing that person is challenging. It's not about that label. When we look at some of the health inequalities for our people with learning disabilities, we know that our women with a learning disability are likely to die 23 times younger than women of the general population. Our men are dying 20 times younger. We know because of the profound and multiple learning disabilities that people have all this complex care. And we see a more complex picture in terms of those health equalities, and they are more likely to need these services and be using those services. So when you put someone who's more likely to need and use those services in an environment where all of this is unfamiliar and strange, we call that social construct. Behavior is a social construct. We all behave a certain way in certain environments. So if I'm at a football match, I'm going to be cheering and shouting and very, very loud. If I walked into my class of student nurses and was behaving like that, I think they might have something to say. So behavior is about a social construct. And when you start to think with people with learning disabilities in that environment, socially constructed environment where they have to attend an acute hospital, where they then only way that they can communicate is through this behavior, same as you and I would do, only we can use our words. And then we start to see that complexities of the adaptive function that I spoke about earlier. We look at that social model that Jonathan was referring to. We look at the language, and then we start to think what the environment needs to change and how can we enable people to be in that environment better. I have worked in behaviour services for a long time, and there is never, you kind of put your finger on it and say, oh, that's exactly what it is. There's a lot of kind of things that you need to adapt and change. And one of the first things that I would suggest that people do is self-regulate. So if I'm not feeling safe and secure, if I don't feel I can intervene to calm this person or communicate to help them understand what's happening, then I need to self-regulate me. I need to have the time to be able to do that. I need to think about how my communication changes. I need to think about other people around. So I'm not the expert on this person with learning disability. So if you are the expert in terms of pressure damage and pressure ulcer, and exactly what you say, Jeannie, we all learn, everyone learns, and we need to develop those strategies to support, but everybody coming together, because the challenge in behavior is created because of the social environment or the social construct that the person finds themselves in.
Right, thank you for that.
All right, I get a wee bit impassioned.
No, it's lovely, Eilish, to see the passion, to be honest. Jonathan, how then can we be a good sort of communication partner? I don't know if that's very sort of, what would I say, layman's language, but I've read a lot about that on the, say, for example, MenCap site. They talk about being a good communication partner. So what things can we do, or do we need to think about? Not sure if you can hear me, Jonathan. Okay, yeah.
It's yeah, all good. It's again, it's always going to massively depend on the person you're working with. But I think the top things that you should always, first of all, if there's somebody who understands that person better than yourself, make sure you reach out and find that information out. Friends, families, other care workers. In working in a school, we're lucky enough to get spend a lot of time with my students. So I develop a strong understanding of how they communicate. But I imagine for people in working in hospitals, sometimes this can be, they've got 10 minutes, 15 minutes, and that's a really hard amount of time to understand how and why someone is communicating the way they do. I can imagine for a nurse or a doctor walking into a room and they're seeing someone who is presenting in a way that they might consider really explosive or very dramatic or very maybe just something they don't want to deal with right then if they've had a long day. But everything that someone is doing, everything that someone does is a form of communication, and they are trying to tell you something. And if someone is presenting in a way that you could call as challenging, they're doing it for probably a very, very good reason, and it's something that we've missed. And we need to consider about the way that they're communicating, and then also the way that we communicate with them. Sitting in a doctor's office and being spoken at for 10 minutes with all, sorry, have I gone again?
You're okay. You're back again, Jonathan.
Yeah,
It's just crackly a wee bit. You're okay. Keep going.
sorry. So, if you're sat in a doctor's office with someone using all this language you don't understand, and they're just talking at you in a way that you might consider too fast, you might not be able to pick up on what they're saying. It's something that even I don't want to deal with, and especially someone who might also then be experiencing other sensory difficulties. They're in an unfamiliar environment. There might be strange smells and people and strange noises. It can become really overwhelming. And I think a commodity that I'm imagining lots of people in your field don't have is time. And I think you probably don't have the time needed to do this in a way that I would think is proper, which is a barrier. That's just a big barrier that you have, and it's something you have to deal with. But I think it's something that we really need to think of more and consider more. You can't just get it done in 10 minutes, 15 minutes sometimes with people. Sometimes people need a lot more space and time to process things than you or I might need, and expecting them to just fit into that box for us because we're helping you. I'm helping you, so you need this. It's not going to work, and it really is only going to make things worse and then require more time to fix in the future. So we're kind of just creating this spiraling issue of I made a miscommunication with you, something's gone wrong, and now we need to fix that before we can get back to the real problem that's happening, which is your health, which is the main reason why you're all here.
Yeah, absolutely. So I'm just thinking of both of you. I don't mind who comes in on this. I'm just thinking that as well as thinking about how we listen better, how we communicate better, so that we can deliver, say, for example, our pressure ulcer preventive care better. One of the key elements of that care is to educate someone on what a pressure ulcer is, and the steps that they can take or carers can take to prevent harm. And I'm going to use our sort of SSKIN model through the rest of the discussion, but I'm just wondering, are things like easy read leaflets, videos, or how do we plan to sort of give that education to people in relation to pressure ulcers in a way that they might understand? And I can already hear you both saying it's going to be very individualized, but I just wonder if you could give us some sort of tips in relation to that.
I think I'll come in first of all. Am I okay to make a wee plug for a bit of work that you and
Absolutely,
I've
you
been
can.
doing, Jeannie? Never miss an opportunity to make a plug. So through Queen's University and the Society of Tissue Viability, we have created a video for people with learning disability, their families and carers, and it explains pressure ulcers and pressure damage, how it occurs, and how to prevent it. So we've done that through a good day, bad day. So keep your eyes peeled, guys. It is going to be launched on
Tomorrow.
tomorrow. My goodness, it's the 20th already. So this came about because Jeannie and I started having a conversation about easy reads. So who are easy reads targeted to? They're not always suitable for the person with a learning disability. Sometimes they're targeted to the parents and carers. Sometimes the person themselves isn't getting that education. And we're living in a technology world now. Video is so much more adaptable. It's so much easy to use, and it's a wee bit more real. So I am going to give that a plug because I think that is a really useful way of kind of even getting the whole message across, or looking at just one particular element of it. You can use it individually with people, you can use it in groups, and you can come back to it time and time again. So people have that visual memory of what it looks like. They have the kind of auditory explanation of what it looks like, and then that helps the person, because of that learning difference and the adaptive function difference. It takes a wee bit more time, and they will then understand the message themselves at that point. So I think for me, I'm going to plug that because I think it's a nice way to give ownership.
Absolutely. And I think one of the nice things about that video is obviously we had a gentleman with Down syndrome, John Moffat, who was an absolute diva. He was fantastic. He was a superb, at acting. And the thing about it is as well, I think people are seeing people similar to themselves. Would that be right,
Yes,
Ailish?
absolutely.
Yeah.
Absolutely. And it's they can identify with it and they can see, oh, well, actually, I will do those things. And I'll let you all into a wee secret. When I was showing this video to my husband, he was like, oh, I didn't realize that sitting on the remote control could cause pressure damage. So my husband learned something as well. So that's the beauty of when you create these things, and when it's adaptable to people with learning disabilities, it's adaptable to everyone. And I suppose when you're thinking about everyone is so unique. And your title on our slides is, are you really looking? Are you really listening? So we can kind of nod and agree, and we can, make those assumptions because we hear someone has a diagnosis of whatever, and we make those assumptions about the language. And I think when you're targeting it towards a person, then it takes away all of those assumptions. You're on that level that they understand.
That's brilliant. And Jonathan, I'm thinking that maybe in a classroom or teaching situation, is it different? I mean, do you have more time? I know teachers are very busy and have a lot to cover in terms of the program for that year. So if you have a
Yeah.
child that's struggling, what do you do?
So generally, we would always ask for help if there's something we don't understand or know about. There are resources out there for us to ask for help from, which I would always encourage people to do. We do need to draw in expertise from other people, because generally you will find the school, depending on the range of training that people have had and their financial situation at the school, they're, they're probably not likely to. I mean, I might be just making a speculation here. I imagine very few schools in the country have pressure ulcer specialists present within them at any time. But the training will generally come through the choice of your senior leadership team and what they feel like you need to learn at that time. And then everything else is kind of on the onus of the individual to say, I don't know enough about this, and go to your senior leader and say, I want specific training in this, or I need help in this. Or perhaps if you've had an occupational therapist come to your school, to then reach out to them further. In line with what Ailish was saying, I really, really agree with, you were talking about, in the information you're trying to present to people, having something in it that they can see in themselves, or an association that they can match to their own experiences. When I've had to kind of extend help out to families and try and get them in or on board with an idea, sometimes some people are a bit opposed to kind of outside intervention, especially if it means coming into their home. They've lots of fear about being judged, lots of fear about feeling like they're on their own. And so in seeing representation from somewhere else and seeing the success it's had really draws them in more to saying, okay, here's someone else that was like me, and this has helped them, so I'm going to do that too. It's a really convincing kind of way of getting people on board with saying, like, oh, here's a great piece of information for you. Please consider it and look at it and use it to help your child or whoever it is that you're caring for. Can be a very very useful tool.
Thank you very much, Jonathan, for that. So sort of if we're following our SSKIN model, the next thing I want to sort of focus on is skincare. And I know that I've often met people who, for example, pick their skin or bite their hands or shouting out or hitting when people are trying to act in their best interest. I wonder, I mean, Elisha, you've already explained why people might be doing that, but I'm just wondering, is there anything we can do to de-escalate those sort of situations, and try and act in someone's best interest?
Yeah, so I suppose I'm always key in terms of the preventative strategies. So what can we do to stop this getting worse? So in terms of the skin care, we're talking good nutrition, good hydration, and we're looking at our personal care, we're looking at good drying of the skin, but not rubbing. And I'm not trying to teach you guys this, that you as the Society of Tissue Viability know all of this better. But in terms of then when we have some of our people who have a learning disability and maybe they have perhaps Prader-Willi and they have different nutrition needs, or they will pick at their skin and those things that, you're biting your hands and all that stuff you're saying. That's the proactive measures. That's where you need to get a wee bit busy and change something. So if someone is, perhaps refusing the creams or the barrier creams, or, not tolerating dressings, then you have to think about how you can incorporate that and, as Jonathan said, make it identifiable to them. So where's the other person, that they can see that has this cream, or where's this bandage? Make it play, make it fun, and do it really slowly. You're not going to, Rome wasn't built in a day. We're not going to go in and just say, this is what we're doing and I'm doing it this way and everybody has to agree. We need to do it very, very slowly. So that desensitization stuff. So if it is about creams, then it's a little tiny bit of the cream. It's about, the person having control over it, giving them the tube, letting them dispense it, apply it. It's about, using the wound dressing perhaps on one of their favorite characters, if it's a child that has perhaps a favorite toy, using that. Perhaps it is about seeing, well, look, I'll have a bandage on me and you can have one on you, and let's see if we can tolerate it, over dinner time today, and or let's see if we can just tolerate it for 10 minutes, and it is very, very slowly that we want to do all of this. It needs to be at the person's speed. It needs to make sense to them, that they can identify and relate to it. It needs to be their voice that we're hearing as well. So not just what we want to do. And that's where the best interest comes in.
Yeah, this is probably an unfair question, but back to Prader-Willi, why is the skin picking such a central element of that condition? Is there any rationale or reason?
There's a lot of science behind it, Jeannie, and there's an area of the person's brain when they have Prader-Willi that doesn't switch off. That says that they're full, and it's the same kind of pain sensation, and it's sometimes it's just there. It's usually, I'm even scratching my own arm doing that, it is just one of those things that we see. And then you have the added complexity of the poor nutrition for someone with Prader-Willi, and poor healing, and constantly picking at it. There's lots of different I suppose phenotypes, or I suppose associated conditions with some of those genetic conditions or neurodevelopmental disabilities that we see in learning disability. So yeah, I don't profess to be an expert.
No, don't worry. It just came into my head to think, why do people, why is it so associated with some of the genetic conditions? Just interested in that. Jonathan, I'm sure in the classroom you've experienced of children with perhaps a learning disability, whatever, saying no to various things. How do you go about managing that situation? I'm just thinking, I'm looking tips for my 2.5-year-old granddaughter, by the way, who's already learned to say no. Yeah.
It's a lot of compromise, is really important, and accepting that, what we want to happen initially might not happen, and sometimes it's going to be a bit of a journey to get there. It's just not going to be immediate, and because I think often we always look at it, and what I get a lot from other people in the profession is things. I'm trying to offer this person this thing to a child that's going to be great for them, and they're refusing it. and I don't understand why they're refusing such a fantastic thing. And sometimes I just say, well, it doesn't matter. They are refusing it. So we now need to get onto that pathway of building them up to a place where they're going to accept it. And sometimes the answer to that can be absolutely ridiculous. And it's just finding these peculiar things about these people that can draw them in. Ailish was talking about, letting people put creams on themselves, having different routines put into place to help them on board with it. We used to, so I can see when I'm cutting out slightly. I used to have a child that didn't like. They had a skin condition. They needed cream applied, and we had to create a song for it. And that was the solution. It was a song, and there was a group of children doing it at the same time as them that were also applying things to their body they weren't applying obviously any kind of medicinal cream, but with their friends getting involved with this song and also placing something on. It got that child to do that happily. And then, it's not something we had to keep doing every day. It just got to the point where then they were happy with the idea of putting that on their body. So then from that point onwards, they would willingly do it when an adult came to them. And if our initial approach was to try and force them into it, or to try and refuse their refusal, it would have just created more negative barriers surrounding it. It would have created more refusals and a longer journey to get to that point, when actually their initial no had to be respected and it had to be understood before we acted on it.
Right. That is really useful. I'm just thinking now about surfaces. One of the things that we introduce to prevent pressure ulcers might be mattresses or cushions that have motors, or might feel different or odd to the person, and they don't maybe want to particularly sit on it or lie on it. It's maybe interfering with their own ability to move perhaps in the bed. So I know, Jonathan, you have an interest in autism, and I'm just wondering about maybe the impact of things like noise or mattresses that are moving or cushions or colors or anything at all like that. Do you think it does have an impact on whether people accept or decline a piece of equipment?
Yeah. There's no doubt that it definitely does. Sensory needs can massively impact someone's choice in the things that they want to touch or be around or where they want to be. Absolutely. I don't know what goes into your design of these mattresses. I don't know if there's a range available.
There is a range, but
one thing that does come to mind as well. Yeah. Research I was looking at, but I could find it. It was very interesting. It was talking about different forms of light sensitivity, and quite often people always just think of bright or dark when they think of light sensitivity. They think of hypersensitive or not, but actually, I was looking into, there's lots of different types of sensitivity towards light. You can think about the fluorescent nature of the bulb, the rate at which the bulb sort of refreshes, and some people can actually pick up on that. And it will create.
I think we're just losing you a little bit, Jonathan. So I'm going to hand over to Ailish. I don't know,
sort of
Ailish.
strobing effect for them, which can be really unsettling. And I'm in this. Oh dear, sorry. Yeah.
You're okay, Jonathan. Thank you. Ailish, do you want to come in?
Yeah, I suppose one of the things that we always see with those kind of aids and adaptations is that people have to use them. So I'm kind of thinking from a nursing perspective about some of our mattresses and some of our cushions that we use. And quite often they're just presented as a fait accompli. So I think this is going back to what Jonathan was saying earlier, having that identifiability that other people use this, having that education around it, looking at all those proactives, and taking a refusal as a refusal, because you end up into a standoff then and nobody is getting anywhere. It needs to be a very slow process, and it can be fun. So like we can have, some of our stickers on things. We can have elderly folks preferred cushion covers on it. Maybe the skin folks are not looking at that, but let's take this slowly, slowly. Let's pick our battles and think about how we can get a way around this. I'm thinking in terms of some of our folks who maybe are wheelchair users, and you have, those adaptations that are, great for posture, but can we build that up slowly? How are we using that at that person's rate?
Lovely. Eilish, we kind of mentioned it earlier, but I'm just thinking about one of our biggest problems. Well, for me, I would say if people are at risk of developing pressure ulcers and their skin's starting to become red or perhaps starting to become a bit purple, and we really need to reposition that person, and they say no. And we know that we're getting really afraid now that they're going to end up with a massive pressure ulcer that potentially could be life-threatening. I'm sort of wondering, have you any thoughts on what actions we should be taking at that point? When you know someone's coming to harm, because I
Yeah.
know a lot of what you and Jonathan have talked about is like a slow introduction, but sometimes, particularly in acute care, I don't feel I have that luxury.
Yes. And I think that this is hugely important. So if someone was coming to harm, either through a potential safeguarding issue, we would not be saying go slowly. And this is the same when someone is coming to harm with that really severe pressure ulcer. They're in an acute environment, so they're already clinically vulnerable with some of those health inequalities that we see our folks with. And we know that people with learning disability do have a more sedentary lifestyle. So it has to then go to those best interests. So we need to be then looking at the aids and adaptations. We need to be looking at how we then build those in. It can still be done in a controlled and predictable manner. So, we can say, okay, we're doing this for 15 minutes and then, you're saying no, so no's no. And we'll come back to you in half an hour. So it can still be controlled. And I think sometimes we're very quick to try and jump in and say I'm the expert, and I would always be going back to say who is the person, what do they need, who knows them well, who knows how to communicate with them, what is it that we need to do immediately that can't be changed, that is a potential huge risk, and how can we alleviate that for the person? So if we're having to do those postural changes, can we do it while we're singing? Can we do it, perhaps in a different environment? Could it be a waterbed? Could it be, can the person get up and walk? Maybe, if they're able to do that. So how can we change this? What is it that the person likes? And to give them the control and ownership.
Right, that's fantastic. That's actually really good because I'm thinking, we'll have people on bed rest and we're sort of turning them from back to left to right. But I suppose if they're able to get out of bed and just go for a short walk, that might be enough maybe to help perfusion to the tissues, for example.
I wish I had the answers, Jeannie.
I know, so do I. Don't always. Jonathan, I was thinking about, and we discussed this before the webinar as well, about an awful lot of young people in wheelchairs in schools. And I sort of, I have the experience of a young gentleman of about 15, very healthy, very fit, very active, probably fitter and active than I am, but wheelchair user, played wheelchair basketball. But whenever I was chatting to him, he was saying, I'm up in my wheelchair from before I go to school, and he's not getting back to bed to sort of maybe 10 or 11 o'clock at night, teenagers on the internet, on their computers, for example. And he did develop a category 3 pressure ulcer, so relatively significant. And I did ask him at the time, have you any opportunity in school to sort of get off your chair and sort of lie on your side? is that anything that anybody ever does within a school environment? You ever come across it?
I mean, I haven't come across it personally.
Yeah.
I haven't, and this isn't from not coming across students in wheelchairs. Uh, it's just not actually something that's um, it's not necessarily something that's actually come up, or it's not been spoken about. Schools would definitely be able to provide something like that if it was identified in their healthcare plan. And it would really rely on the professionals who have designed that plan to have identified it as a possible danger or threat, or whatever, kind of language you use to describe it. So it would really involve who's involved in the process of designing that and then ensuring that it's in place. Because if the if the requirement for that to happen would be extra funding, that funding could be provided. If it was deemed by a professional, it's always going to have to come from a professional somewhere. Someone's going to have to sign off on it and say this student needs this, and so they're going to need, if it means that you need some kind of specialist equipment, if it means that you need a space in the school that they can use for a certain amount of time, someone kind of needs to flag it with the okay. A lot of the times at our level, what can happen is we get kind of stumped
Yeah. And I'm just thinking that as a
by somebody's not. Um,
John,
Carry on.
I was just saying that I was thinking as a healthcare professional, I to think that I haven't thought this through enough to think that
Mm,
this needs to be, something that's flagged as part of their educational plan, if that's the right
mm,
terminology, that there needs to be some thought given to pressure relief throughout the day because it's a very long time. I mean, obviously, when the young guy came home, he could, lie in his bed if he chose to for a short period of time to relieve the pressure. But I'm not sure that
mm.
young people are really being taught to do that. Or, we're really trying to encourage people to do some of their leans to the left, to the right, to the front,
Mm.
to the back. What can we do? But not when always people have the good stability to do that. So I think it's something we need to probably talk more about as a community, probably.
Yeah, it would be. Yeah,
Yeah,
definitely. And if it got brought
yeah,
up more, yeah,
yeah,
Jeannie, I'm just going to come in just on one wee point because I did take a wee note to myself when we were speaking about this. And just to say that that wider MDT working is there. So
yeah,
there will be a registered nurse and learning disability in the local community. There will be perhaps an acute liaison nurse. There will be specialist nurses who know this person, who are able to work with them. So it is literally only a phone call away. And we need to remember that we don't all have the answers. There's no one specific thing. So, there will be a team of behaviour
yeah.
practitioners and nurses and learning disability that will be able to support and guide this as well.
And I'm really hearing that through this webinar. The importance of that multidisciplinary team approach. Um, Thank you so much for that. It's really thought provoking. I was going to say when we're thinking about sort of surfaces and moving and handling and things like that, Eilish, one of the problems that I see in practice is I see families continuing to lift and move their adult son or daughter in a similar way to they did when they were a baby or child. And I'm wondering how can we get people to do this in a safer way because we've got lots of aids and you know
Yeah.
things that people could
And,
be
and
using.
again, there's lots of reasons why that happens as well, Jeannie. So there's that kind of idea that you know, the parents are still caring for the children, even though the child is growing and is an adult now. And we see that kind of, it's an eternal child. And while that is improving at the minute, there is still an element of oh, they've got a learning disability, oh, they've got Down syndrome, and
Yeah,
sometimes there can be that element of treating the person as an eternal child. It might also be, maybe the environment, might be the home environment isn't appropriate, where the bedroom is, and, the person with a learning disability might like that specific bedroom, but it means that the hoists and everything don't really fit around the
yeah,
door frames, and the house is being designed for people who don't use wheelchairs and hoists, and they haven't got wider doors. And there can be lots of reasons around that. And I suppose one of the biggest things that impacts this as well is is the carer fatigue. We see carers have an amazing job, but it is a huge responsibility. And they do it 24/7. They do it when it's unseen. They do it at 6 in the morning to 6 at night to 12 at night. And it's a huge unseen issue.
Yeah.
They will have the answers for this. They will know how to kind of look at this. But when you're thinking about that movement and encouraging people to move, it's at their level as well. And again, I don't have the answers for that. But I think sometimes when you're at least putting yourself in the perspective that there's many factors at play here, that it's not just they can't be annoyed. Because often our carers and family members are doing over and over above and above.
Absolutely. And I see that every day. I mean, you really do have great admiration for, the way that they do care for their loved one. I suppose I'm thinking that, from very early days, we should be teaching about pressure ulcer prevention, good moving and handling, the use of equipment, etc. We've kind of talked a little bit about moisture, Eilish, and I'm sort of actually realizing I can't believe it's 20 past already.
Who knew we could talk?
I know, I tell you. So guys, if any of you have any questions, please don't be afraid to pop them into the chat, and we'll do our very best to answer them in the time that's left. So I'm not really going to go back too much, Eilish. Well, maybe I will to moisture. Is continence and toileting a major issue within learning disability?
Yeah, probably going back to the issue that I was talking earlier on, that it is an adaptive function, and I suppose elimination and continence would be one of those adaptive functions that maybe takes a little while longer for people to learn, or then we maybe see when they have a health deterioration that there is a deterioration in their continence levels, and we might see maybe some of our folks that have profound and multiple learning disabilities are maybe never able to acquire that function. So continence is a huge issue in terms of working and supporting people with learning disabilities and moisture and making sure that the skin is intact. And we see folks, a lot of the times maybe the way they eat and means that they have certain contractures, or sorry, the way that they eat means that maybe the food's kind of getting over their hands due to contractures, or maybe perhaps they bite that hand and it's salivation, and maybe the hand's contracted and it's trying to get into all the crevices to keep the skin nice and clean and dry. And so a lot of times it is around the person's position. It is around maybe those skin folds and body position, around some of those kind of behaviors, the hand biting, maybe excess salivation, and incontinence is a huge one as well. Yeah, absolutely.
Yeah, okay. So I think I'm going to just move on now to our last element, which is nutrition and hydration. You've already mentioned a good bit of this, but what I'm sort of wondering is, are there any hints or tips from both of you? I'll start with Jonathan, as to how we can encourage healthy eating and hydration.
Oof. Yeah, this does come up a lot. It comes up a lot with children anyway at school, but especially for our children with additional needs. Sometimes it can be as simple as changing the way the food is presented, is a big one for us. Quite often it's about how it looks or seems. I've got lots of students who I've come across who don't like having their food mixed, or touching each other can come up. So being able to understand the reason why they're not engaging in a certain diet that we want them to is very, very important. It's not always, I think a lot of people just think it's the flavor and they'll go straight for flavor, or they'll say, they're not eating this food. They only want to eat unhealthy types of food because of the flavor. They just want to have chocolate or something like this. But actually it's because of the temperature or
I've never ever
texture.
thought about
hydration. Let me just wait till I come back in.
Sorry.
You're okay,
sorry, Jonathan.
I hope most of what I'm saying.
It is. It actually is.
It's there's so many different reasons than just they don't want to eat, or or it's because of how this tastes. And you can try so many different things. Just present the food differently, change the color, foods with different colors, foods with different textures, different times of days, different, not wanting to, it might just be the time of day. I, for years, hated eating breakfast as a child. And I just didn't like eating at that time of day. And if someone was trying to force me to do that every day, I'd probably develop a very negative relationship with that specific meal time. And it might just be a good idea to try and work around that. Hydration is not really an issue I come across too much. It might be something better for Ailish to talk about. I've not actually faced any issues with someone drinking appropriately throughout the day.
Yeah, I suppose nutrition, I suppose I will take it from both extremes that we see an increase in obesity in population. We know that our people with a learning disability have that sedentary lifestyle sometimes that increases that risk of obesity. But we also see that kind of risk of malnutrition on the other end as well. So where perhaps people have profound and multiple learning disabilities, maybe they have swallowing issues, they need modified diets. And we are seeing some of those issues around malnutrition as well. So it is that broad spectrum. And it's also to remember that, perhaps like our folks with Down syndrome have smaller stature, so their BMI calculation would need to be adjusted because it's for kind of average height person. Going back to that kind of eternal child thing, do we use food as a reward? Like, I know I am always bribing myself. I'll do this and then I'll make a cup of tea and I'll have a biscuit. But if I'm doing that for myself, then how many other people are doing that for the person with a learning disability?
Thank you both so much. Folks, we're down to our last couple of minutes.
Some questions.
Heidi has noted, and I can very much I very much feel what Heidi's saying, that she often feels out of her depth if she needs to assess a person, usually an adult with a learning disability. She doesn't have much experience and they don't get referred to them very often. So what tips would you give me to feel more confident about my first few minutes of meeting the person so I can feel confident and they can feel confident in me?
I'm going to go with that one because I would be saying just get to know them, Heidi. What are they interested in? Can you do a wee bit of background information? Do they need any reasonable adjustments to their communication? Bring our video, show them who you are as what you're going to do. Don't set out to do it in one fell swoop. Go and say hi, create that relationship, come back, ask some of your questions. Yeah.
Yeah, I think that's really useful.
Involve the
Jonathan?
nurse and learning disability, involve the MDT.
Yeah.
Absolutely.
I would say that probably everyone in your field and in your profession has got 1,000 stories about having challenging work with someone who does not have learning difficulties. So really, let's not think of it as any different. You're going into an environment with a patient, and whilst you may know going into it that they might present in a different way, you've probably overcome lots and lots of challenges with people that you consider to be difficult patients, or they gave you something that you had to overcome before. And it's just new and it's just going to be different. And actually, sometimes it might even be 50 times more pleasurable or enjoyable. And you can meet some really fantastic people that way, I think. It doesn't have to be negative. And if we get that out of your head and just go in with a positive view on it, you'll have a great time with it, I'm sure.
Yeah, I know. I was just reflecting earlier on today. I was caring for a gentleman, who's basically been sort of neglecting himself a lot, and he's quite nasty leg ulcers, and very unkempt. And he was absolutely terrified sitting on that couch, waiting for me to do sort of my Doppler exam and whatever. And anyway, I realized he had an Arsenal shirt on. So, we spent the whole time talking about football.
Right.
I know nothing about football, but it absolutely got him engaged and chatting away. And I just sat and listened and prompted him with a few wee questions, and we were able to get through what we had to do. And that was really useful. Folks, so many thank yous coming through for the helpful tips and thoughts, and you'll be able to have a wee read through some of the webinar chat afterwards. But And that's for Eilish and Jonathan to say a huge thank you for all the giving up your time today. And to all those who've joined us on the webinar, I know that evenings are very, very precious, and we really do appreciate you giving up your time to learn more about pressure ulcer prevention when caring for a person with a learning disability. And folks, do look out for our video tomorrow. We're really excited. As Eilish said, we think it will be a really useful resource for you to use to generate discussion, to stop the video where you need to stop and ask those open-ended questions to see what people understand and what take-home messages that they might have. So we're bang on 7:30. So folks, just want to say thank you very much. And we look forward to maybe catching up through social media or whatever. Someone's asked, will a link be forwarded for the video? And I would say yes, but you'll also be able to access it through the Society of Tissue Viability social media, whether that's on Facebook or through X or whatever. So please go onto our website and you'll get the links. So thank you very much, everybody.
Jeannie, I just want to acknowledge Fiona's comment, and we have a comment there from Jonathan, who's a student nurse, way up the student nurses. Jonathan, thanks for that one. And Fiona, I am delighted to see that this is the first time you've had some learning disability experience, and please do just get in touch with your local learning disability team, guys.
Yeah. Thank you, everybody.